we'll get started. We already have over 20 people on the line. So I just want to remind everybody that you're welcome to identify yourselves if you want, but you don't have to. If you want to use a pseudonym like Donald Duck or just your first name, that's fine. The meeting is being recorded so that we can make it available on the website for people who couldn't make it, couldn't be with us tonight to still hear. So I think everybody knows who Dr. Chapman is, but I'll just say that I think the most important role, of course, is that he's the chairman of the Medical Advisory Board for Alpha-1 Canada. You probably disagree with me, but Dr. Chapman's obviously a world-renowned researcher and clinician in the area of alpha-1 antitrypsin deficiency, among other things, asthma and other airway diseases, COPD. And if anybody can tell you how to get the best treatment for your alpha-1, it's certainly Dr. Chapman. So I think I'll turn it over to Dr. Chapman. He's going to talk for about half an hour, and then we'll open the floor up, and you can ask him some questions. So thank you very much for being here, Dr. Chapman, for busy, and take it away.
All right. Well, good evening, at least for those of you whom it's evening, and I am Ken Chapman, and I gather, according to the program, meant to be nattering on for about 30 minutes about alpha-1 antitrypsin deficiency, and I know from some preliminary back and forth that at least one person is on the line with interest in alpha-1 related liver disease, but I'm afraid my background and focus will be on lung disease. I might still say a few general things that are applicable, but the general discussion is going to be around lung disease. It's a bit of an unusual setting for me to speak to an unseen audience, and for that matter without slides, and I haven't done a poll to find out what people really wanted to know, so we're going to count a lot on that question and answer period. But I thought I'd do my best to share with you what I think are some of the key messages, some of the things you may not have heard before. And you'll let me know at the end how well I hit that target. So how do you go about getting the best treatment for your alpha-1 antitrypsin deficiency? And I think everyone on the line is doing the most important first thing, and that is to educate yourself. And there are lots of ways of doing that. The library, of course, was the traditional way. Now we all go online. We can find information, of course, on the Alpha-1 Canada website and good links to other websites, the AlphaNet website in the United States, the Alpha-1 Foundation, the Alpha-1 Registry in Canada is in the midst of revamping its website, and there'll be some increasingly useful links there. I say educate yourself because, as I think just about everybody in the line has discovered, doctors, Canadian doctors and doctors in many countries, are unfamiliar with alpha-1 antitrypsin. It's not as rare as many doctors think. We often point to other very well-known diseases, so we'll point to cystic fibrosis that people have heard of, may be familiar with, may have read stories in the newspaper about, and we'll say that alpha-1 antitrypsin deficiency is as common as cystic fibrosis. You can be pretty sure that your family doctor's heard a bit about cystic fibrosis, has a rough idea of how it's diagnosed and treated. You can't be sure that the same is true of alpha-1 antitrypsin deficiency. So when I say go out there and educate yourself, what I mean is you're going to have to become, to some degree, your own specialist. Now, I've limited my comments so far to family doctors, you'll say, but of course my lung specialist or perhaps liver specialist will be very familiar with this disorder. And I have to tell you that's not necessarily the case either. And I won't name names, and nobody can reach me to twist my arm, but I can give examples. I think Heather's on the line. She could probably give some examples as well, where we've come across specialists who are not too familiar with alpha-1 and who may be making mistakes. So educating yourself is your best way of ensuring that you're going to get the best care, because step number 2, you're going to educate your doctor. And they say, how do I do that? Well, one really good way, and it's what all patients should be doing regardless of problems, is asking questions. Asking questions about the diagnosis, asking questions about management, and asking questions about various options. Rarely is there only one treatment option in any chronic disease setting, and that's certainly the case with Alpha-1. If you know some of the rudiments, if you know what's being done in various centers, you can ask your doctor if you're a candidate for this or that. And if you're going to ask those questions, it might help to write them down, because we all get a bit busy and flustered in these appointments. We get sidetracked by some issue, and then we realize as we've left the appointment we've forgotten to ask, and if it's your specialist and you see him once a year, you've lost the opportunity perhaps for another, or somebody who can keep the appointment with you. It's great if there are 2 of you to ask the questions, and by the by, also to listen to the answers, because sometimes it helps to compare notes afterwards to see if you've both heard the same message in response to your question. Next step may seem fairly obvious, but you need to see a specialist. Now, I'm going to pause there. These days, especially in the big cities, we are specialized to death, and it seems that there are not only lung doctors, there are left lung doctors and right lung doctors and sub-specialists. But I just want to draw to your attention that not everybody who's a respirologist or lung specialist is necessarily attuned to COPD, emphysema, or to alpha-1 antitrypsin deficiency. Your regional, your local lung specialist, the person you may have been referred to initially, may have general background in respirology, but may make his or her living doing critical care medicine or doing sleep disorder medicine. And if that's the case, you might want to see if there's an opportunity to shuffle sideways to find somebody whose focus is really lung diseases like emphysema, and in particular something like Alpha-1. So you might say, gosh, that all sounds pretty critical. How do I know if the doctor I'm seeing is really up to scratch, if he or she is doing a good job on my behalf? So let's talk a bit about the encounter you might have with the specialist, I'm assuming here lung specialist. What are some of the things you need to put on your list and tick off? And of course, there are the general factors, and I'm not going to get into those. Is this somebody who is accessible, you can make appointments with? Is this somebody who can speak in plain English, can give you the information in a way that's comfortable and sensible to you? Those are all general doctor-patient issues. But to come to Alpha-1 and lung doctors, has your lung doctor absolutely verified your diagnosis with the specific diagnostic test known as either genotyping or phenotyping? I'm going to pause for a minute there, and maybe I'll describe that to you. In Canada, in all the provinces, if a doctor wonders about alpha-1 antitrypsin deficiency, it's a simple matter of ticking off on a blood requisition a request for a serum measurement for alpha-1. It doesn't cost the system very much to do those tests, about $6 or $7. They're pretty reliable tests, and the answer will come back. But here's the surprise to most non-specialists and even some specialists. A low serum level doesn't firmly make the diagnosis of alpha-1 antitrypsin deficiency. It's simply the signal that there's something there that needs a closer look. And to firmly make the diagnosis of alpha-1 antitrypsin deficiency, you have to figure out what sort of genes, 2 of them, are making alpha-1 protein in the individual. Now, we can do that directly with genetic tests in this day and age, but there's a little bit of a drawback. Those genetic tests will only identify the 2 most common abnormal genes. The Z gene, the one most responsible for alpha-1 antitrypsin deficiency, and the S gene, the one that tends to be responsible for lower levels of alpha-1 antitrypsin in people of Southern European background. So if you've got one of the less common variants, and there are about 100, you may not get adequately diagnosed just by genotyping. So it's out there, it's pretty good when it works, but it isn't foolproof. The other test is phenotyping, and the general idea is that the protein in your bloodstream gets analyzed, and a good lab can figure out if you have normal protein, called M protein, associated with the M gene, the normal gene, and a lab can also figure out if you've got Z protein, the abnormal protein, or S protein, or one of the others. And it's in many ways a more definitive test, but it's also a trickier test to do in the laboratory. Now, all of this gets very much complicated by a couple of other factors. First of all, the specific testing, the genotyping, the phenotyping, is not routinely covered by provincial fee schedules. It is in some provinces, not in others. And it's not readily available everywhere, and your doctor might have to do some homework. And lately, as many people will know, we've had a problem in Canada. Much of the testing in Canada has been referred to Dr. Diane Cox's lab in Alberta, in Edmonton. She was one of the initial people in Canada to work in this area, and she's a well-qualified geneticist. Unfortunately, she's working only in a research laboratory, and her university had some purely legal concerns, technical concerns, that a research lab shouldn't be allowed to do clinical testing. So all of a sudden it became much, much harder in Canada to get the appropriate testing done. At the moment there's a stopgap arrangement in place whereby one of the companies involved in Alpha-1, Telecris, you'll be familiar with it, has sponsored testing to be shipped out to a laboratory in Gainesville, Florida, run by the world expert Mark Brantley. So, number one, has your doctor just stopped at the serum level, or has he gone on to do phenotyping or genotyping, and do you know those two bits of alphabet that define your disease? If you can say, I'm a ZZ and my doctor showed it to me on a piece of paper, then your doctor's done a good job on that initial step. If it's all based on serum levels, the job of diagnosis isn't complete. Number two, as you were getting this sorted out with your doctor, did your doctor think about the inheritance pattern of this disease? Did your doctor start looking around to see who else in the family might have this problem? The interesting thing is, universally in my office, every adult I've seen with Alpha-1 has always asked the same question about family screening. What about my kids? And I'm a parent, I think I'd be asking the same question. But to talk just statistically for a moment, alpha-1 antitrypsin deficiency is unlikely to appear in your children. The odds are running at about 2%. The most likely place it's going to show up in your family are brothers and sisters. And that leads to all sorts of problems, because when I'm talking to adults with Alpha-1, typically brothers and sisters may be scattered across the country or even in other countries. Sometimes brothers and sisters don't talk to one another, and of course I have no direct access to brothers and sisters, but I hope that your doctor at the time of diagnosis raised this issue, that there are other folks out there, your blood relatives, who need some screening, and I hope your doctor offered to facilitate that or communicate those messages to help that screening take place. By the way, if it hasn't, we're happy at the registry to help that process take place. I said we were talking tonight about lung disease for the most part, and I suspect that most of the audience are people who've had lung issues, and that's how their diagnosis was made. But I hope that if your doctor, your lung specialist, was doing a thorough job, he or she raised the issue of liver disease and suggested perhaps that your liver be tested at the minimum with a blood test or two, and maybe even more elaborately with a an ultrasound of the liver. And I hope the lung specialist also took some time to say, and by the way, if you're old enough that you didn't routinely get hepatitis vaccination, it's about time you did. Because though you may have primarily lung problems, we do know that abnormal alpha-1 protein does build up in the liver of people with lung disease, and that as they get older, their chances of also getting liver disease can increase. I don't want to say too much, although I'll certainly answer some questions about it in terms of specific prescriptions. As everyone here knows, I think the treatment of alpha-1 to some degree is the same as treatment of other COPD-type problems. In other words, if you've been a smoker, well, you absolutely must stop, and one marker of having a good lung doctor is that he or she is willing to help you do that. And there are all sorts of tricks and techniques and smoking cessation aids. You should get a sympathetic hearing, and I'm glad to say that the sort of people I trained with many years ago are no longer as evident. I mean the sort of doctors who say, well, quit smoking or don't come back and see me again. You probably received prescriptions for inhalers, and I think it's a very good idea, and I think most people with alpha-1 should be on fairly maximal therapy, which typically means a once-a-day inhaled anticholinergic. The one that's on the Canadian market is Spiriva, and a twice-a-day typically inhaled combination. There are two of them on the market. The brand names are Advair and Symbicort. Most of the time, that so-called triple therapy, 3 different drug compounds, are what people with any degree of alpha lung disease should be on. And another marker of good care, hope your lung doctor made sure that you knew how to use your inhaler. Either he or she taught you, or watched you use your inhaler, or made sure that somebody in the office or nearby did. By the way, one of the other keys, I think, in good alpha-1 management is to make sure that you're as protected as you can be at the highest risk time. And by that I mean when you're in the midst of a flare-up. As you know, I think, the problem with alpha-1 antitrypsin deficiency is that alpha-1 antitrypsin protein is normally there in good amounts in bloodstream and in the lung to protect the body from its own defense mechanisms. What I mean is, if you're fighting off an infection, white cells go galloping off to the site of infection. So let's say it's a chest infection. White blood cells are there in the lung. They gobble up bacteria, and the way they kill those bacteria is to splash something called neutrophil elastase on them. Think of it as a strong bleach. Believe me, that's about the extent of my biochemistry as well. And the alpha-1 antitrypsin protein is there to mop up any spills of that neutrophil elastase. If you don't have enough of it, when you're in the midst of a chest infection, your own white cells may not just digest bacteria, they may digest, eat up, and damage your own lungs. So you want to put a stop to any chest infection right away. And by the by, this applies to general COPD, the typical tobacco-related variety as well. We say to all of our patients, if you get chest colds and bronchitis, you should have on hand, right there in the medicine cabinet, an antibiotic and perhaps even prednisone tablets that you and your doctor have agreed that you're going to use ahead of time. And my patients are always told, when you get increased phlegm, colored phlegm, and a bit more difficulty breathing, start right away on that antibiotic and prednisone that we've agreed upon in advance. You should have that sort of self-management plan, and that's something that should have been clarified with your doctor. One of the more contentious issues, I suppose, or complicated issues would be what we call now augmentation therapy, and that's the specific therapy for alpha-1 antitrypsin deficiency. It's sometimes referred to, I suppose, incorrectly as replacement therapy. We're actually just augmenting, though. We're just boosting blood levels of alpha-1 antitrypsin protein. The way it works is this, if you're unfamiliar with it. The protein is carefully filtered out and purified from donor blood. And the purified protein is available in Canada in the form of the brand name Lastin. And people with alpha-1 antitrypsin deficiency can receive either once a week or sometimes once every 2 weeks infusions of this purified protein that boost their serum levels. By the way, they don't boost them all the way up into the normal range usually. The goal is to boost it up into a protective range, which is a little lower than normal but higher than it was. The reason this treatment is a bit contentious is that when it appeared about 20 or 25 years ago, there were not a great many centers that had a great many alpha-1 antitrypsin patients. And although the researchers developing the protein, developing the prolastin, could be sure that the protein was pretty safe and pure, that it got into the bloodstream and stayed in the bloodstream and splashed into the lungs. In other words, it all looked pretty good theoretically. They didn't have enough patients around to test in what's called a randomized controlled trial that lung function was preserved in people getting the protein. It worked out that in order to do a proper scientific study showing benefit, they would need about 500 patients getting prolastin, about 500 patients getting infusions that weren't prolastin, just placebo, and they'd have to follow those people for somewhere between 3 and 5 years to show preservation of lung function in the group that was receiving the prolastin. It was an impossible trial. It was an impossible one in terms of not enough patients, cost too much, couldn't be done. What happened in the late 1980s is that when the treatment became available in the United States, the American Thoracic Society, the specialist society of all the lung doctors, said, well, it makes awfully good sense to us, and you can't really do a trial, so we're going to recommend use in people who have lung disease and alpha-1 antitrypsin deficiency. In Canada, the approach was much more conservative, and you'll have to remember this was just after the HIV problem had surfaced, and there was concern about blood products. The Canadian Thoracic Society said, well, you know, it's interesting, but we think more research is necessary. Well, 25 years later, there's a lot more information about alpha-1, and I'll simply summarize by saying all of the observational studies and some very clever X-ray studies have convinced most of us that this prolastin really does protect the lungs. But there still is no one randomized placebo-controlled trial with 500 patients in each arm followed for 5 years. It's never been done and is not likely to be done. However, the Canadian Thoracic Society has warmed its statement somewhat, and it acknowledges that it's a treatment that should be considered in some people with important lung disease that's progressing. So, let's come back to you and your doctor and figuring out whether your care is good or not. I think that your doctor should be pretty comfortable discussing prolastin with you. In fact, your doctor should raise that issue and make sure that you're aware of it. I've been pretty shocked in the past to encounter patients with severe and progressive lung disease who had no idea that a very specific therapy was out there and potentially available for them. And whether or not your doctor supports it, wants to pursue it, recommends it to you, your doctor should be at least familiar with it. This is an area where there's room for some debate. And that leads me to my next point. You should, if you're not sure about the answers you're getting, not be shy about asking for another opinion. And you can't see a face. I'm glad this isn't a webcast. I'm sitting here at my desk at home and casually dressed. But if you could see me, you'd see the gray hairs, and you'd recognize that I've been around doing lung disease management for a while. And I'll tell you that I found that the really good doctors never mind a second opinion. In fact, as I get older, I sort of think of it as getting a chance to share the blame with another doctor. So in fact, if I'm stuck and seeing something that I'm just not comfortable, I've got a complete handle on, I'll often raise the issue with the patient. More often than the other way around. I'll say, you know, I really appreciate your seeing Dr. So-and-so or Dr. such-and-such. I'd really appreciate his or her opinion, because this is really a tough problem. And I know that's not always an easy thing to do. It's not always easy, for example, because you don't want to offend your doctor. It's not always easy because logistically, if you're in a remote part of Canada, you may not have ready access to this, that, and the other specialist. But I think at the end of the day, it's your life, your lung health, and if you approach it diplomatically and say, I gather I might be able to get additional information over there with Dr. So-and-so, I don't think a good doctor should take that amiss. And I'd encourage you to do that. And you might get a different perspective, or you might just find out that your doctor's been doing an awfully good job, as most of them are, and you go away reassured that all the right things are being done. Never hurts to ask. Never hurts to get somebody else to have a look at it. There. I think I've spoken to the title. Jim gave it to me and said, here's what you're meant to talk about. I'm going to shut up now, and I guess Jim is going to field questions and give me a chance to answer them. That is, if anybody's still on the line, and we'll see how I reach the target or not.
So thank you very much, Dr. Chapman. Who wants to start? Carol, you usually want to start.
I have a question.
Go ahead.
Tim? I believe I heard the doctor say increased phlegm, colored phlegm, difficulty in breathing, start your antibiotic and or prednisone immediately.
Mm-hmm.
When do you feel comfortable using the prednisone?
I think that most doctors would agree with the antibiotic as a first step, and whether or not you take prednisone is probably a question of how bad your lung problems are and what kind of lung problems they are. So if you had a diagnosis of Alpha-1 but you had relatively mild obstruction, then maybe just the antibiotic is enough.
Mm-hmm.
If you had Alpha-1 but very severe obstruction, you'd probably be wise to take both of those things at once, both the antibiotic and the prednisone. Some of my patients will end up approaching it as a two-step plan. They'll start the antibiotic, and if that works, they're happy. And if they still struggle on day 2 or day 3, they'll add in the prednisone. It's not an exact science, but the important thing is to have a plan before the event. Some people say, my family doctor doesn't like to do that. Well, if your family doctor doesn't, we either need to educate your family doctor or we need to make sure your specialist writes prescriptions ahead of time. Some people say, my doctor will see me when I get sick. Yeah, but you know what happens? Everybody gets sick on Friday night before the long holiday weekend.
Yeah.
You get to see your family doctor 5 days down the road, and that's 5 days of those white cells with their neutrophil elastase splashing around in your lung. So it really is important that you, the person who first knows about the infection, is in a position to do something with it.
I see. Thank you. And would you start off at 50 milligrams, or if you did have a lot of difficulty?
For some reason, I tend to write a prescription of 40 milligrams a day for 7 days. Some doctors write 50 milligrams, and that's mostly because there are 50 milligram tablets that mean you only have to swallow 1 tablet rather than 8 little ones. And then some of my patients are very, very sensitive to prednisone. Some people say, it's great for my chest, but I just get wonky and irritable, and I start getting really spacey, or I just can't sleep all night. And some of those people will back off to 30 milligrams a day. So it's in that ballpark. It's 30 to 50 milligrams a day, somewhere between 5 and 7 days.
Thank you.
May I have a follow-up to that one?
Go ahead.
This is Phil Gerritsma from St. Catharines. For all of the reasons of not abusing the medications and, generating resistant diseases and so forth, I don't want to use these medications if not really necessary. As a consequence, because I get infusions anyway, the nurses have volunteered that if I have an infection that's only throat but not lung, they're willing to do just the test with the stethoscope to listen to my lungs to see if it's really in there or not. Is that a good idea, or should I be taking the antibiotic even if the infection may be limited to my throat and not to the lungs?
No, I think if it's in your throat, you're not coughing up phlegm, or at least phlegm that's no different from usual. If it appears to be confined to the upper airway, great. When it appears to be descending into the chest, start the antibiotic. I hear you about antibiotic resistance, and it's interesting. I think in the past we may have been concerned that our patients would overuse antibiotics that we gave to them. But I must say that's rarely the case. In fact, if I think about my COPD patients generally, I will usually write these prescriptions in advance, and at second and third and fourth follow-up visits, I'm often explaining to somebody why, in retrospect, they should have used that antibiotic for that flare-up 3 months ago. In other words, I find myself still needing to encourage people to use that antibiotic plan. Rarely are there patients who are a bit silly about it and misuse antibiotics. Occasionally there's a misunderstanding and somebody fills the prescription right away because they thought they were meant to take it right away. So bottom line, I think much more often we need to encourage people to take those antibiotics rather than restrain them.
Thank you.
I have a follow-up question as well. I get frequent sinus infections where there's all sorts of colored phlegm and all that sort of thing that comes down, and I cough it up, but it's mostly coming down from the sinuses, not up from the lungs. So should I be taking antibiotics fairly quickly? Often I wait for a week or so to see if it's going to go away on its own. And occasionally it does, but more often I end up taking the antibiotics anyway.
Well, I think if you've seen a pattern, you should probably assume that pattern and just deal with it. The other thing I might say is if things seem to start in your sinuses, part of your evaluation should be to see if you have allergies, some skin prick testing, and it may be that some anti-allergy treatment like nasal sprays for the nose will prevent those episodes of sinus infection. Doctors are quick to write antibiotic prescriptions for sinus infections. They're not always as careful to make sure that the sinuses are draining adequately, that the passages are open so that some of that material can be released. There are things like the anti-inflammation nasal sprays, things like Avelox, Nasonex, Rhinocort, Rhinolar. People in the audience have probably been on some of those. And then there are the saline rinses to rinse out any infected material. Long answer. I'm sorry, I'm an academic. I tend to do this. Jim will tell you it's a bad habit of mine. But the quick summary is, yeah, I think if you've seen problems start in the nose, then you should probably start treating the nasal things. And treating the nasal things is more than just an antibiotic. It's probably making sure the sinuses are open and rinsed.
Okay, like I use Nasonex regularly, and they rarely go down the chest, except that I cough up the phlegm that it goes down the back.
So the Nasonex isn't holding it completely?
A combination of Nasonex and pseudoephedrine, by and large, does most of it.
But saline rinses are available without a prescription at the drugstore, and sometimes rinsing at a time of worsening is a good way to keep things under control.
Doctor, it's Hugh Smith. I'm about to start the augmentation therapy, and my current level is 0.19.
Yes.
And I wondered what the protective level was.
It's about 0.6. That is to say, and I know we corresponded about this, say hi to him for me, should check your serum level just before your next infusion, and it should be at or just a little bit above 0.6. Okay. That means that you're protected for the whole time between infusions. By the way, you don't do that with the first infusion. You'd wait through about 5 infusions, and then you'd do that when you were at what doctors call steady state.
Thank you.
I have a question.
Yes.
I was diagnosed about a year ago with alpha-1 antitrypsin deficiency and mild COPD.
Mm-hmm.
My lung function tests are all pretty good,
Good.
My FEV1 is over 100%, and the one thing they've noticed is a gradual decline in the diffusion capacity.
Mm-hmm.
So I'm wondering what kind of precautions I should be taking. The doctor has told me about augmentation therapy, but I'm not a candidate for it, by any of the criterion that there are right now. So what advice would you have, as far as the Spiriva and everything goes, too?
Without obstruction or developing obstruction, you may not be in need of inhalers, but I wanted to get back to one of the points that I raised earlier. Do you know your genotype, your phenotype, those two little bits of alphabet that describe what you've got?
ZZ.
ZZ.
Yeah.
It looks as though you've got a pretty good genetic package otherwise. That is to say, Alpha-1 is just one of the things, of course, we inherit from our parents, and there are other genes as yet to be defined that help influence lung health. So everything else you inherited from your parents looks like it's doing a good job in protecting your lungs. I'm going to guess, and you'll embarrass me by telling me I'm wrong, but I'm going to guess that you're either a non-smoker or you've just barely experimented with cigarettes when you were in university, and that's also another reason why you've got good lung function now.
No, I'm definitely a non-smoker. I always have.
There you go.
Yeah. So.
And then you mentioned your diffusion capacity going down. You didn't give me a number there, did you?
It was 92%, the first one, and the last test it was 80%.
Well, I have to tell you, it's one of the more variable of the lung function measurements, so by itself I'm not too excited.
Okay.
And it doesn't usually drop all by itself, so I just wait on the next measurement before getting too interested. You might want to do some measurements of oxygen, like oxygen when you exert yourself. Sometimes there are some surprising shifts in patients with Alpha-1 at a time when we wouldn't expect it. That is, as compared to people who have COPD of the more usual sort. I'm not too concerned about the diffusion capacity numbers and changes you've just described. Sometimes people get a little too focused on the numbers, and there's a fluctuation in them, and sometimes the fluctuation is not very meaningful. You really get a sense of this disease and how it changes over 3 or 4 years, not between two sets of measurements 1 year apart.
Okay. So then what I understand then is there's no reason to start with the Spiriva or the antibiotics or anything like that?
Well, actually, I'm going to say there's no current indication for the Spiriva.
Okay.
I would speculate, and don't quote me, that there might be some role for an inhaler of some sort, like an inhaled steroid, because the protein that is circulating is a little bit abnormal. It clumps together, and it's a little inflammatory. So you might even make an argument for a low-dose inhaler. But I have to tell you, as long as you promise not to quote me, I'm just speculating here. This is a bit of scientific hypothesis. I have no proof on it. But you, to come back to the question, probably don't need the Spiriva, the whole triple. You might, if you were interested in doing everything possible, take a low-dose, say, anti-inflammatory, an inhaled steroid. However, the other part, the chest infections, yes, if you got a chest infection, that is when you are at greatest risk of losing some lung function. So I would put you into a different category. In other words, you're not a healthy 15-year-old teenager who can afford to cough and hack for a few days and miss a day or two of school. You are somebody with a lung that's a little predisposed to damage. You should be starting an antibiotic right away.
Okay.
And I think that's a wise precaution to make sure that those very good lung function numbers you're talking about stay good.
Okay. Good. Thank you.
I'd like to ask if anybody else on the line is concerned like I am. I've been receiving Lastin since 2002. I was diagnosed with Alpha-1 in 2001, and I just heard that when my prescription runs out, I won't be allowed to receive Lastin anymore. Is anybody else on the line concerned about this?
Yeah, I am.
I think it's done me a world of good. Since 2002, I haven't gotten worse, touch wood. I'm practically, since I went to rehab, slightly improved, but I know it's because I know I'm receiving this Lastin that I just know when we're in trouble, it kicks in, and we aren't going to be able to get it.
May I ask, how is it you're receiving it now? That is, how is it covered?
I get it because I get home care, and I get it. I don't pay for it, and I cannot afford it.
And this is in the province of?
Ontario.
And you're getting it from the drug benefit formulary of the province?
I have home care comes, a nurse gets me, I get it ready, and a nurse gives me the IV, and it's CCAC, I'm trying to think, St. Elizabeth Healthcare pays for it. And I know every year I have to apply for a Section 8. And okay. I know that Section 8 has to be a new subscription. So it says that new subscribers will not receive Lastin. And I know, I just think that in February when I have to reapply that I won't be able to get it.
No, I don't think that is the case, actually. From your description, you're receiving the Lastin under the drug benefit formulary, and you're quite right. There has been a change, and Jim can tell people more about this, but the drug benefit formulary has, for the present, stopped approving new prescriptions, that is, new patients.
Prescriptions, but what's the Section 8?
It is approving or continuing to approve, at least to the present, repeat prescriptions for people it has funded in the past. So unless there's been some remarkable change in your circumstances, I believe that you will be eligible for a repeat.
Oh, what does the Section 8 mean?
It's not called Section 8 anymore. They changed the numbers just to confuse doctors. But what it means is that there's an approved list of drugs that doctors in the province can prescribe that will be paid for by the drug benefit formulary.
Yeah.
First, there's a large list, and it's all the general drugs, no questions asked, no problem. Mm-hmm. There's a smaller list of special drugs that are called limited use drugs, and you just have to look up a little code number and write that down. And then there are other drugs that aren't accounted for at all, and that's things like Lastin. And so if doctors have written a thoughtful letter describing why their patient needed one of those drugs, the drug benefit formulary could approve the drug. And Lastin, it's a very odd situation. There has been a policy of approving Lastin in the past. There have been some criteria in the past, and without any warning, the drug benefit formulary reversed course. They've pretended that this is not a change in policy, but it absolutely is. And I think Jim could talk more about what Alpha-1 Canada is trying to do about that in terms of raising awareness and perhaps changing policy.
So you don't think I have to worry?
Well, I think you always have to worry when it comes to the government paying, but I think I just make sure that I'd spoken to my doctor at the time and got the appropriate letter in a timely fashion.
Oh, I always do.
My understanding is it should not be an issue for a repeat prescription.
Yeah, I've been repeated since 2002.
Shouldn't be an issue.
Jim here. What the government has told us is currently they're reviewing their policy. They're not approving new patients, that is, patients who've never received Lastin, but they have no plans to cut anybody off who's already on the treatment.
Because I really,
they can always change their mind. They do it all the time. But,
yes.
But so
think in your mind, in your heart, that it's working.
And that's why it's really important for people like you to write to Helen Stevenson. And
I did.
And basically to tell, I'm speaking to everybody now, to tell her exactly that I've been on the treatment for this long. I think it's done me a world of good. All the things that you told us, because she's at a point now where her expert committee has told her twice now, you should stop paying for this.
Can I get another form letter sent out to her?
Well, if you've already written to her, I don't think I'd write again. But
okay.
I'm just, I'm speaking to anybody else who, and I was going to do this at the end anyway, that we've got, getting patients to send letters was step one. We've got a number of steps planned to get this decision reversed, we're going to be like a dog with a bone on this one. If Helen decides no, then we're going to go talk to Helen's boss, and if she says no, then we're going to, if we have to go to Dalton McGinty's office.
Okay, so nobody stopped looking.
Oh, heck no. This is, I just want to make sure people from other provinces understand that, Ontario is the big guy on the block, and it's not at all uncommon for other provinces, to, especially something that's going to save the money, to follow suit. And it's also not uncommon with private insurance companies who don't want to spend all the time doing these studies to do what the government does. So, this isn't just about Ontario. This is about access to treatment, across Canada, both through the government plans and through the private plans. It's just, this is too important an issue for the community.
For sure. I agree. I've been on Lastin, and I just was in December for 6 weeks at a rehab in Toronto at West Park Place, and it's the best thing that it's changed me, the way I can manage showering, washing my hair, doing anything, and then my Lastin on top of it. You think you've maybe, got a handle on things, and got that slatter. So hopefully we can still receive the Lastin, and I recommend Pulmonary Rehab to anybody. It really helps if you're having problem with breathing.
Yeah, that's really good advice. Thank you.
Just, you cannot believe breathing exercises. I do it faithfully every day, which I never used to do. And every day I do one of their exercises they tell us, and it's really, and I go for a checkup in the middle of April to see how I'm doing. And it's the best thing I could have ever done.
That's wonderful. Are there any other questions?
I'd like to follow up. I don't want to interrupt.
No, if you have a follow-up, mine's a different question, so I'll let you go first.
The follow-up is, I am presently on a private plan. When my wife retires in about 6 months, that plan will not cover me. Will the Ontario government at that time see me as a person who is presently receiving it and would continue it in the sense that they would take over payment, or will they regard me as a new patient that they will refuse?
They would regard you
I'm in the same situation.
They would regard you as a new patient whom, if your wife turns 65 tomorrow, you'd be turned down.
Ouch.
Yeah. That's why this issue is just, I think I can safely say probably the most serious ones that we faced as an organization, and why we're pulling out all the stops to get this, to make sure this goes the right way.
Yeah.
Elizabeth?
I had 2 questions, very quick ones. I have 2 children I'm bringing up. One is 12 and one is 8. The younger one, his mum's placenta was tested when he was born, because his brother is a ZZ. He is a Z. And I wonder if he's at any risk. And the second question I had was that the boy with the liver disease, Wesley, is he at risk of getting lung disease as he gets older?
Let me answer the second question first. It's a little easier. The answer is yes. It's not clear why some people develop liver disease in childhood, some people develop lung disease in adulthood, and although it tends to be one pattern or the other, people can be unlucky enough to get both. So obviously all of the important information about no smoking, etc., are going to be important for the child with liver disease. Now, I'm not sure if I understood the first part. I understand that the child with liver disease is ZZ.
Yeah.
And then you said about his
brother. I have the two children. Jacob, the younger one, is Z, and his placenta, or his mum's placenta, was tested at birth. But he actually caught H1N1 from his brother, who was hospitalized with it. But he caught it and just recently and got croup afterwards, and that's the third lot of croup he's had in his 8 years. And I wondered if he's at risk of having lung disease too, even though he's only got the one gene.
Now, when you, and I still want to get back to that, when you say Z, I'm not sure what kind of test that is. Do you mean, or were you told it's MZ, that is, he is a carrier with one abnormal gene and one healthy?
He's a carrier, yes, that's what they said.
Then in general, it's a bit controversial, but we believe that the risk of liver disease and lung disease is very small. There's a little abnormal protein being deposited in his liver, but in the absence of some other major insults, like developing hepatitis C or, heaven forbid, in some distant future, alcohol abuse, that's unlikely an issue. Same sort of thing with the lungs. We think that the risk of emphysema or COPD is relatively small in somebody who's an MZ, in somebody who's a carrier. Having said that, there's probably a little something going on because many years ago some of my colleagues surveyed asthma clinics and found that the number of carriers was about 4 or 5 times higher than expected. So there's probably a little something going on, but it's not the major risk for an MZ that it is for a ZZ.
Oh, thank you.
Maybe just another
antibiotics.
Sorry, another quick follow-up just to emphasize 2% of the population is MZ, and most of those people go entirely unrecognized. It's an invisible carrier status.
Yes. Thank you.
Somebody else was trying to
Dale.
Go.
I have a question on antibiotics. Recently there was an article about Avelox causing liver damage. I wondered if you could speak to that and if there are any recommendations for those of us that have lung and liver involvement now, what antibiotics we should be avoiding if we have liver disease as well.
I'll be honest, I have not caught up to that particular publication about Avelox and liver disease. It's a shame. It's a good one that we often use in people with lung disease. And sometimes these reports are, I hesitate to say exaggerated, but taken out of context, they may look more serious or worrisome than they truly are. In other words, a rare liver problem with this particular antibiotic is perhaps no more than an occasional side effect, as we might see with almost any drug. But in answer to the more general question, so what about antibiotics if somebody with liver disease needs them? There's a long list of antibiotics that could be used for lung disease. In fact, it's often said that the exact choice of antibiotic for COPD exacerbations is not very important. And people say you can use tetracycline, you can use Biaxinin or clarithromycin, brand name, generic name, Z-Pack, Zithromax, or azithromycin, you can use sulfaguard. It really doesn't matter for the vast majority of flare-ups or exacerbations. So if you regard Avelox as being relatively contraindicated, something you wouldn't want to take, there's a long list of other things you could take.
Okay. Thank you.
Any more questions?
I just have one more then, in respect to the antibiotic. Do you change the family of antibiotics?
I do. That's not based on any evidence, but a vague notion that perhaps we should keep the germs from becoming resistant. And I will tend to alternate between two different classes of antibiotic if somebody needs them. But with any luck at all, people don't need them very often, so it's a moot point for most of my patients.
I hope you'll come back.
I don't know. I don't know anything else. Not at all.
And Dale, we'll see you in a couple of weeks. I have an appointment with you.
All right.
Okay.
Yeah, I just found that this Health Canada issued the Avelox liver injury warning to health professionals on Monday. Following a safety review of Avelox side effects, the reviewers concluded that Avelox can cause rare but potentially fatal liver injury and liver failure. Health Canada is requiring Bayer to update the label warnings.
I was on Avelox last spring. I had 2 different lots of it, actually, but I was also on 2 or 3 other antibiotics in a 4-month period, and my liver enzymes certainly went way up, and my spleen became enlarged, and I did suffer some side effects from one of the drugs during that time frame. So I just wondered if perhaps it was the Avelox.
Well, if there aren't any more questions, and since we're almost at a couple minutes away from 9:30, at least where I am, I don't know what time it might be where everybody else is. I want to thank Dr. Chapman for taking the time out of his not a busy schedule, but I guess his free time late at night to take part in this. I'm pretty sure that when we put the recording up on the website, that this one will be a number of other people listening. But once again, thank you, Dr. Chapman, and I want to remind everybody about the issue in Ontario and writing to Helen Stevenson. If you don't have the details, you can certainly find it on our website. There's a link right on the homepage, something called Ontario Government Withdraws Funding, blah, blah, blah. So thanks, everybody, for joining us. I appreciate it. Have yourself a great evening and a great weekend as well. Thank you very much.
Both. Thank you.
Thank you.
Take care.
Bye-bye. Bye-bye.